right. So I just want to acknowledge that I'm joining from the unceded and stolen traditional territories of the Coquitlam First Nation, which lies in the shared territories of the Tsleil-Waututh, Katzie, Musqueam, Kakite, Squamish, and Stolo nations. And so as someone who is an uninvited guest on these lands, I specifically want to send thanks to the Coquitlam First Nation for their continued and unfailing commitment to stewardship on the lands that my family and I spend much of our time on. I also want to speak here to the kinds of commitments that I make every day in the work that I do and that my team does in trying to unlearn colonial myths, trying to show up as a good ally, trying to talk about where possible, to educate others when they're not familiar with colonial history and colonial violence, and really working to ensure that the research that we do goes beyond not reinforcing myths, but also actively works towards decolonization. I also recognize that this is a lifelong process and an ongoing journey. I want to position myself as a cis white woman with she, her pronouns and who is not living with HIV. So I have had the privilege of working with various communities of people living with HIV for almost the last 20 years on and off, and I'm incredibly grateful to do this work and for the amazing collaborations, leaders and advocates in the community who I take guidance from and work alongside and whose passion and commitment fuels the work that I do. I also want to note in positioning myself that I'm a parent to 3 young kids, 5, 10, and 12, all of whom are home today with various severities of illnesses. And today is actually day 12 of round-the-clock high fevers for the 5-year-old. I'm also partner to a person who needs to be teaching at UBC right now, but romantically, he developed a fever and cough last night and is actually teaching from home today. So I hope I won't be interrupted, but I apologize in advance if I am. I also want to acknowledge a lot of support and love for the peaceful counter anti-trans protest that's happening very shortly, if it hasn't happened already, at the Vancouver Art Gallery in response to national anti-trans mobilization to protest SOGI curriculum pronouns and gender identities. And I hope anyone who was kind of waffling over going to this talk or going to the protest went to that instead, and sending warm thoughts if you want to rush and go there because there's still time. So I also just want to take a moment to acknowledge that a lot of the topics covered today can be difficult and experienced by different people in different ways. You need to take a break, take a breath, or leave completely, no worries. I'm also so grateful to hear any feedback that people have on these talks, so please be in touch if I can speak to these issues in a better way or a different way. I was asked to speak this September as part of World Sexual Health Day and Month, as Andrea said, and the theme for this year is consent. So I have tried to align the focus of my talk around issues of consent that are important for women living with HIV, and in particular intersect with sexual health. And so I'm focusing here on the sentence on this slide that speaks to how it is essential to respect and value everyone's autonomy in sexual matters, regardless of gender, sexual orientation, or any other factor. I've organized the talk into 3 themes. So first, I'll speak to what consent in sexual encounters means for women living with HIV within the current legal climate, and how complicated and difficult these discussions are for women living with HIV who need to consider how and when to disclose confidential medical information to potential sex partners in a way that people with no other chronic health condition do. So I'll further describe the role of gendered sexual relationship power in shaping these discussions. Next, I'll look further into what disclosure of HIV status means, of potential harms and benefits of HIV status disclosure, and how the idea of consent plays out in these discussions. And finally, I will discuss some strategies to support the health, safety, and well-being of women living with HIV in light of the previous discussions. So first, I want to speak to the SHANA project, which is the source of much of the data I will draw on for the research presented today. So SHANA was initiated in 2014 after many months of community consultation and interest from the community to do a study with women living with HIV. There is a quantitative cohort side of the project where we collect information at baseline and every 6 months using survey approaches. To date, we have interviewed 384 women as part of SHANA. We have a clinical side as well where we offer sexually transmitted infections testing, as well as collect viral load and CD4 as key outcomes in the study. We also have an amazing qualitative side of the study, which historically has been led by Dr. Crucy, and has some really amazing and longstanding qualitative and arts-based projects, some of which I'll speak to today as well. We've also started a new digital storytelling project within Shauna. So this is the Community Research Hub where our project office is. It hosts the project activities across a number of different projects. It's operated based on community-based principles of reciprocity and a spirit of collaboration across projects to ensure that participants' needs are met outside of just participating in the studies here. So we have daily drop-in hours, 10 to 4, with multiple spaces for participants to relax in, coffee, snacks, tea. We have a clothing donation place, as well as food pantry systems that are set up to support participants. We host a number of different events there, including community forums, community advisory board meetings, and the Shauna Positive Women's Advisory Board. Shauna holds a monthly drop-in day on the first Thursday of the month, which might be the only space left, we're told, exclusively for women and non-binary and gender diverse people living with HIV to come and do this drop-in, while there are other spaces that host similar events. We also have a clinical room with a sexual health nurse, which is outfitted to meet the needs of our clinical side of the studies and provides trauma-informed care and connections to other health services. This infographic shows some characteristics of women in Shauna. You can see that the median age at baseline was 43 years of age. About 3/4 of women have parented or given birth to a child. I just want to make a note on gender identity in Shauna. In recognition of the gaps in research and access to care among women living with HIV at the time of our grant applications back in 2013, 2014, Shauna's recruitment criteria has been self-identified women, which is inclusive of cis and trans women living with HIV who access HIV care in Metro Vancouver. 1/3 of women had sexual minority identities, including lesbian, gay, bisexual, asexual, queer, or two-spirit. 10 had gender minority identities, including trans, non-binary, gender diverse, or two-spirit. Overall, 7% identified as trans women and 93% as cis women. 13% of Indigenous women identified as two-spirit. And so while eligibility continues to be women at baseline, over the course of the study is able to recognize fluidity in gender identity, and 5 people identify as genderqueer and non-binary at follow-up. We recognize and acknowledge the tensions and not wanting to erase the gender fluidity, but we also acknowledge that the study did not adequately recruit or sample gender diverse and non-binary people based on that original eligibility criteria, and call for more research that is inclusive of people with diverse gender identities. So I'll start with the first theme related to what consent and sexual encounters means for women living with HIV in the current legal climate. As I'm sure most people here are aware, HIV has become a chronic and manageable health condition from the 1980s, when it was a serious acute condition with a very high mortality rate. The change was largely due to increased efficacy, reduced side effects of medication, as well as regimens that were more manageable. There have been efforts to make HIV medications affordable in some places, and including in BC, where they're free of charge, to promote medication uptake and in an effort to reduce HIV stigma, which continues to endure. Activists, healthcare providers, advocates have been really supportive of shifting discourses around HIV to normalize HIV as a chronic disease like any other kind of disease or condition. But despite these biomedical advances, it hasn't really completely been possible to do this or remove the stigma surrounding HIV or remove it from political areas. So in reality, HIV isn't just like any other chronic condition. It's unique in the way that it's criminalized and in the way that it's stigmatized. The criminalization and stigmatization of HIV is really highly linked to sexual health and consent and sexual relationships for people living with HIV. So in short, as described on this slide, people living with HIV can be criminalized if they don't disclose their HIV status to their sexual partners under certain circumstances. So as a preface to this, I'm not a lawyer, and the specific details of legal policies are outside the scope of my expertise, but these topics are really so critical to some of the areas that we do research in, so I try to bring it in here. Basically, 10 years ago, the Supreme Court in Maybeer said there's no realistic possibility of HIV transmission when a person has low viral load, which was less than 1,500 copies of the virus per milliliter of blood, and uses a condom. And so in that case, if both conditions were met, the person is not legally required to disclose. It's less clear whether or not there was an obligation to disclose in other circumstances. But since 2012, since that time, there's been growing recognition, including in some cases and policies, that a person with suppressed viral load, which is considered right now under 200 copies of the virus per milliliter blood, then in that case, the person does not pose a realistic possibility of transmitting HIV, even if they don't use a condom, meaning they don't need to disclose their status to their sex partner. So in Canada, though, the law has been inconsistently applied in some cases. What constitutes a realistic probability has been interpreted very broadly by prosecutors in court in Canada. So by this, I mean that in Canada, people have been charged and convicted for non-disclosure, even if they had no intent to transmit HIV, posed little to no risk of transmission, and did not actually transmit the virus. Canada is, in fact, Canada stands out as having a high number of convictions, and it's considered that Canada overcriminalizes HIV non-disclosure. So there's no formal laws regulating HIV non-disclosure. So people living with HIV who are accused of non-disclosure are most commonly charged with aggravated sexual assault, which is the same charge that violent sexual offenders get. The assumption is that without having knowledge of their partner's HIV status, the person not living with HIV could not consent to the sexual encounter. We know that levels of knowledge and awareness of the legal implications vary across different groups of people living with HIV. But even if knowledge and awareness were ideal and everyone was on the same playing field here, it's really important to also recognize and realize that not everyone has the same ability to meet the requirements to avoid criminalization of HIV non-disclosure. So with respect to that condition surrounding condom use, research conducted by Dr. Krusi and her team, which uses qualitative and arts-based methods, has highlighted that gender-based power imbalances within heterosexual relationships create challenges for women living with HIV when they attempt to negotiate the use of external condoms. So women have often had limited control over the decision to use a condom. That ends up placing a really heavy and inequitable burden on women with HIV to disclose their HIV status, even when their partner refuses condom use. So they risk violating HIV laws and are at risk of prosecution in those cases. So the idea of relationship power can be really important in these discussions, and we drew on Shauna data to try to investigate relationship power from a quantitative perspective and with respect to potential implications for criminalization of HIV non-disclosure. This is the sexual relationship power scale, which is not perfect and was really designed initially for heterosexual relationships. But it's a 23-item scale developed by Plurwitz et al. In 2000. You can see that it includes two subscales, one on relationship control and one on decision-making dominance. In Shauna, we asked this of people's main sexual partners, and so you can see the screenshot that shows some of the questions that we ask. A limitation, like I say, of this scale is that it was developed only for heterosexual relationships, although we've modified it for the purposes of this analysis. We've limited to analysis with cis-man partners. So here are some graphs of some key prevalences from this scale. On the left is data we collected at one point in time, which is the first interview that participants respond to, their baseline interview. This could be anywhere from 2014 to 2022 for our participants, because we're constantly enrolling people and continue to enroll people today. So for this analysis, we had 228 women with intimate partners who contributed data to this descriptive analysis. That is about 62% of the overall Shauna cohort. So in this one interview, which is really just a random snapshot in time, 5% of women or 9 women with an intimate partner said that if they asked their partner to use a condom, their partner would get angry. And 2% or 4 women said that their partner would get violent if they were asked to use a condom. I'm reading these numbers out specifically because even though they are small and relatively small prevalences relative to the overall number of people in the study, they're important. Anger and violence are really scary and certainly enough to shift balance of power in a relationship and affect if a condom is used. And this puts women at risk for criminalization of HIV non-disclosure if they don't have the agency to insist on condom use as a result of these inequitable power relations in their relationships. So if we expand the variable to capture anyone who has reported these outcomes over the course of the study period, recognizing that everyone's study period and length of being in the study is different, we find that 13% or 30 and 8% or 19 people reported that their partners would get angry or violent if they were asked to use a condom. In addition, looking at the graph on the right, 76% or 3 out of 4 women with an intimate partner report that their partner has more power in their relationship than they do. And 91% report that their intimate partner has more power. So basically, looking at these results, we can say that not all women living with HIV have the same ability to insist on that their cis-man partner uses condoms, and some have very little power in sexual relationships. Some would experience violence if they ask their partner to use condoms, and yet condom use has historically been used as this criteria to criminalize women for non-disclosure of HIV status. So in addition to discussing the challenges and complexities of meeting condom use as a condition, we can also discuss the use of HIV medication, which is associated with viral load suppression, as well as viral load suppression itself. There has been a fair amount of research that suggests a high degree of correlation between relationship power and condom use and intimate partner violence and reduced access to the HIV care continuum. In a recent paper under review with violence against women and done by a medical student who's now resident, Dr. Carol Hay, we wanted to look specifically at how power was associated with HIV care access. And so you can see from this table that we found that the odds of being on ART were twofold as high for women who had high power versus those who had low power, and that the odds of optimal ART use in the last 3 to 4 weeks, which is greater than 95% use of medication, was twofold as high for women who reported high relationship power and medium relationship power versus low power. So these results suggest that higher power in sexual relationships is associated with better access to HIV medication, and the corollary here is that lower power is associated with reduced access. Dr. Cruci and I have also been working on a study that she is leading to identify women living with HIV at risk for criminalization of non-disclosure of HIV status during these sexual encounters, and also considering Canada's approach to HIV criminalization. In multivariable analysis, you can see some really critical social and structural markers of marginalization associated with viral load suppression failure, but that also place women at risk for being criminalized. There are clear markers of economic and social marginalization and discrimination, including food insecurity, housing insecurity, and criminalized drug use that are highlighted in these results as factors associated with not having viral loads measured at greater than 200 copies per milliliter in the last 6 months. Sexual violence by any perpetrator was also associated with having high viral load measure. So you can see that women who aren't even given the choice to consent themselves to sex acts may then be at risk of criminalization during sexual encounters if they don't disclose their status. So we've talked so far about some of the difficulties and complexities women face in meeting the conditions for not disclosing their HIV status to their sexual partners. The process of disclosing HIV status to sexual partners, as well as within other relationships, family, friends, is also very difficult and complex. So in a perfect world, or at least one that was free of HIV stigma, the disclosure of HIV status would be neutral or something that benefited the person living with HIV. One main potential benefit that has been identified is that disclosure can allow for important connections to health and social services, including HIV treatment and care. We've also had some participants speak to how compared to folks with the same barriers to health services as they have, like poverty, discrimination, addictions, food and housing insecurity, living with HIV has actually allowed them to access other services through faster and more efficient referrals. These social services could include HIV-specific housing, low-cost or free food sources. There are some clinics, for example, Oak Tree Clinic in Vancouver, that provide amazing women-centered, trauma-informed, and interdisciplinary services located at the same place that women can get access to. That kind of access can be life-changing for women living with HIV. Along the same lines, some people living with HIV feel that when they are comfortable and when it's safe to do so for that person, disclosing HIV status can help reduce social stigma overall about HIV, as well as reduce internalized stigma, and encourage other people to be open about their status too. And we work with someone who does disclose their status openly, and she says that she does it because it saves lives, and that's true. It really does break down a lot of those barriers. Disclosure of HIV status has been shown in various research outputs to be positively correlated with social support, quality of life, and reduced levels of depression or depressive symptoms among women living with HIV. In relationships, the disclosure of status can, in some cases, strengthen relationships. We've had reports, provide support, allow a bit of relief when disclosing, and so can also, in some cases, be positive as well. At the same time, there have been demonstrated harms to women from disclosure. Evidence suggests that women who self-disclose are more likely to experience enacted HIV stigma. So that is acts of stigma perpetrated directly from another person. Disclosure of HIV status, including through mediators of HIV stigma, is also associated with psychological harms like increased depression or anxiety. People who disclose their status can experience workplace discrimination. They're also at risk for loss of other opportunities, including through education and employment. Marginalized and vulnerable women living with HIV are disproportionately burdened by challenges to safe disclosure, and in particular, sex workers and women who use criminalized substances. HIV status disclosure can also have negative impact on relationships, including violence by partners who use threats of disclosure as control tactics. It's also important to note that, even knowing about the complexities and difficulties of disclosure in relationships can be enough to discourage women from even seeking relationships. And this can have an effect on economic and financial security, social isolation, loneliness, mental health, and positive sexual health. So going back to some of our previous discussions, in some relationships, women may face violence if they disclose their HIV status, violence if they insist on condom use, and risk violating the law if they do not disclose. The complexity of benefits and harms of HIV status disclosure in relationships are illustrated and highlighted by these two quotes here from, again, a fantastic qualitative study led by Dr. Crucy on the intersections between HIV criminalization, stigma, and disclosure. So an HIV diagnosis can shift the balance of power in any relationship. So that includes between family members, friends, partners. For Heather, in this quote in the light green, there was a worry about disclosing HIV status, but disclosure ultimately was felt to be more positive and relationship building. At the same time, in the current legal context, threats of disclosure to others by an abusive partner can further reinforce power imbalances. And so this is seen by Amity in the second quote in darker green, whose partner used her HIV status, unfortunately, to further stigmatize her and included threats to disclose her HIV status without her consent with the purpose of harm. For women living with HIV, then deciding to whom, how, and when to disclose their status is an ongoing and evolving process. Sometimes the agency and ability to actually make these decisions themselves is taken away, and HIV status is disclosed without consent. So while there are the approaches that we've discussed to criminalize the non-disclosure of HIV status, there's currently limited to no recourse for people living with HIV whose HIV status has actually been disclosed without their consent. There's also really limited research and information on HIV status disclosure without consent. But we've heard so much from women in our study about so many occasions when their HIV status has been disclosed without consent and the negative implications that follow. So we looked at the prevalence and correlates of HIV status disclosure without consent in a recent study published by a PhD student with Shauna, Mika Otsuka. You can see the survey item we used here, which was really highly workshopped with participants and piloted with staff. Mika's research showed that among 299 participants with a little over 1,800 observations over 7 years of follow-up, almost 40% of participants had their HIV status disclosed without their consent in the last 6 months. And by the end of the study period, 62% or almost 2/3 had their HIV status disclosed ever or in the last 6 months without their consent. In discussions with our staff and the Positive Women's Advisory Board with Shauna, people wanted to point out really strongly that this is definitely an underestimate and limited to times that women knew their status was being disclosed. And there are many other times where they wouldn't have the opportunity to know. Disclosure of HIV status on a micro level can happen by many perpetrators. We found that the majority of perpetrators were actually people known to participants, and in fact, in some cases, very well known. You can see from this graph. HIV status was most commonly disclosed without consent by friends, people in the community, and family. And then after that, health providers were identified as disclosing status 20% of the time. Then after that, more people who are well known by participants, including neighbors, intimate partners, and acquaintances. So given the limited research available on these topics, we also looked for empirical quantitative associations in our quantitative data. So one study that drew on an earlier and smaller sample of the Shauna cohort found that HIV status disclosure without consent was associated with multiple forms of HIV stigma. So this is shown in this dark blue. And so the HIV stigma types included anticipated, enacted, and perceived HIV stigma. We also found in research conducted by an MSc student, Daniela Barreto, that having HIV status disclosed without consent ever in women's lifetimes was associated with increased risk for verbal and or physical violence that women attribute to their HIV status. And so this is also a form of an enacted HIV stigma. We've taken a look at how HIV stigma has varied since we started collecting these data in Shauna in 2015. You can see that levels of HIV stigma has been sustained approximately the same since September 2015 until that follow-up period that included the COVID time period between March and September 2020, when it appears that levels started decreasing. This is promising at first glance, but we do need to look into this in more detail. So just like everyone else, people living with HIV retreated from the same social realms that they had previously in COVID, and so were less at risk for enacted stigma. People living with HIV had many more options for remote access to health and social services. And so women that we were able to even connect with during follow-up surveys in those immediate follow-ups after COVID had different characteristics than those we followed up previously, or at least were a subsample of women that we followed up previously. These were women who were able to be connected with remotely, who had good access to technology. And we know from other analyses that they were less likely to use criminalized substances, less likely to be at risk for overdose, less likely to experience violence, have housing insecurity, among other markers of social and structural marginalization. So in general, these women may have been at lower risk for HIV stigma to begin with, or other forms of intersectional discrimination and stigma that intersect with HIV stigma, like poverty and drug use stigma. The decrease hasn't been substantial overall, and we will continue to look at this. We've also conducted a path analysis to investigate HIV stigma as a mediator in the relationship between HIV status disclosure without consent and depression, social support, and HIV medication self-efficacy, all of which are really important mediators themselves with on the pathways to HIV medication use and viral load suppression. We identified and acted HIV stigma as fully mediating the relationship observed between HIV status disclosure without consent and depression, and noting that both HIV stigma in itself and mental health have been important factors associated with access to the HIV care continuum. Within the Canadian legal context, where HIV non-disclosure remains aggressively prosecuted, HIV disclosure without consent really violates women's rights to privacy and self-determination. Being outed without consent, whether intentionally or inadvertently, may increase the risk of HIV-related violence, as we can see from our previous work. In this climate of HIV stigma and criminalization of non-disclosure, non-consensual HIV disclosure and the resulting negative outcomes are really made permissible, including violence. All right, so to summarize some of the discussion so far, I've discussed the conditions that need to be met to avoid being criminalized for not disclosing HIV status in sexual relationships. I've talked about how difficult and complex meeting these conditions can be for women living with HIV and how gendered relationship power dynamics can hinder and help. I've also talked about how difficult and complex the idea and act of disclosure of HIV status can be unto itself, the potential benefits and the harms of HIV status disclosure, including without consent. So I'll just close with some recommendations that I feel can help address some of these upstream harms and support women living with HIV to achieve positive health, safety, and well-being, including sexual health. So to start then, there have been a number of really important recommendations made by the Canadian Coalition to reform criminalization, to reduce the impact of criminalization of HIV non-disclosure on people living with HIV and reduce HIV stigma. So if you haven't had a chance to go to their website, they lay all of this information out in a really readable and accessible way. So I highly recommend it. They've made several recommendations, which include removing criminalization out of the realm of sexual assault laws, as well as limiting any prosecutions to cases where transmission of HIV is intentional. Ending HIV stigma is also critical and really requires a multi-level approach to changing social attitudes, providing increased education around HIV, advocating compassion and support for people living with HIV. The message of U equals U, or undetectable equals untransmissible, needs to be integrated both into routine healthcare, but also throughout all aspects of society. U equals U is to say that people living with HIV who take HIV medication and who maintain and achieve an undetectable viral load effectively have no risk of transmitting HIV sexually. So in the realm of healthcare, because evidence suggests that most women living with HIV have experienced trauma and/or violence, interest in trauma and violence-informed practice, trauma and violence awareness, trauma responsiveness, all of which include and encompass a holistic understanding of people's life experiences and how these experiences affect engagement in healthcare services, has been growing in the last few years. And even within our study as well, we've found that 95% of women have experienced some form of violence in their lifetimes. This excellent and comprehensive women-centered HIV care model that I've just copied from a paper and put here on the left, and developed by Lutfi and colleagues as part of the CHIWOS project and many other projects that they're involved in as well, outlines how acknowledging the high prevalence of violence and trauma experienced by women living with HIV and the intersecting oppressions that many women experience should be the foundation for practice and care with women. So certainly, trauma-informed practice with women living with HIV needs to incorporate an awareness and understanding of an enacted HIV stigma and non-consensual disclosure of HIV status as a form of verbal and emotional violence. And providers need to be able to respond appropriately and understand responses to these experiences by people living with HIV as they would any other experience of trauma and violence. A trauma-informed approach with women living with HIV needs to include a focus on confidentiality, safe disclosure of HIV status, and approaches that don't re-stigmatize people living with HIV. Providers need to understand that discussions of consent in sexual relationships, sexual health, and sexual violence may all have different implications among women living with HIV, and orient these discussions in an understanding of the current criminalized context for HIV non-disclosure in Canada. As part of trauma and violence informed care and practice, honoring the autonomy, collaboration, women's wisdom and strength through safe disclosure is critical. And so I've just included this visual of a toolkit that was developed out of a study from the Women's Health and Women's Hands Community Health Center. It really outlines an amazing way to support women in safe disclosure and consider all of the different factors that go into those discussions, and really takes it step by step. So taking a step back to where we started in speaking about World Sexual Health Day, the bottom line here is that everyone, just like everyone else, women living with HIV should be able to enjoy a happy, healthy, safe sex life. Their medical information should be confidential. They should have autonomy and choices in sexual matters, free from HIV and other forms of HIV stigma and discrimination. So sometimes people want to know what they can do and if there's any actions they can take right now. And there are actually a few, and that I will list here in the next few slides. So there are really some great actions that you can take. So first, you can go to this website of our wonderful colleagues at the BCC3 study, who are building on many, many years of past community-based research to do some important advocacy and campaigns. On this website, you can sign to endorse and commit to advance sexual and reproductive health and rights of women living with HIV as part of their effort to build a national movement. Another great idea is to host a Love Positive Women event if you're connected in with communities of women living with HIV. We celebrated Love Positive Women in February of this year in our monthly drop-in, during which participants made Valentine's cards for each other and themselves to show love and support. And most importantly, you can listen to the stories of women living with HIV in their own voices. There has been, there are a lot of these out there, but there is a growing body of truly wonderful campaigns, movements, and contributions that are arts and literature based and work towards reclaiming sexual rights and destigmatizing sexual health in all aspects of living with HIV. These include this fantastic blog, which includes writings by women living with HIV that grew out of the study CHIVOS that I mentioned earlier, and really aims to shift discourses on risk and transmission to pleasure and positive sexuality. And on the right, there's a screenshot of an incredible film called HIV Made Me Fabulous, which we actually were thrilled to view as a team on Shauna in the last, I think 2 weeks ago. We hosted some of the folks who worked alongside this film, and they facilitated a really dynamic and insightful discussion. This film speaks to all of the complex issues surrounding disclosure, stigma, joy, love, and passion that women living with HIV have to face as they navigate dating and relationships. And in the same spirit, I just want to highlight some amazing outputs from our team as well, which include Dr. Margaret Erickson's PhD thesis, knowledge translation aspect of her PhD project. This was an animated video developed with a working group of Shauna participants to illustrate some key findings related to identifying points of intervention for women as they transition out of carceral settings into the community in order to support their health services access once they're back in community. Dr. Crucey's Photo Voice project, which I've spoken to several times today, was really just an amazing project that women still talk about, and really was done to better understand criminalization and HIV stigma. Closed with a really wonderful event in the community. And finally, we have more recently embarked on a community-based, strengths-based digital storytelling project called My Story, My Way, which will enhance the findings from the qualitative cohort and is focused on understanding what trauma and violence-informed HIV treatment and care means to women living with HIV in Shauna. So I want to close by acknowledging our amazing community partners and collaborators and our large team of project staff and trainees who just do such an amazing and incredible, passionate, committed, and enthusiastic work with Shauna. And thank you all for being here today, and for your patience and support. And I'm still thinking about everyone at the counter protests, so I'm hoping that is all going really well as well.